Hi, I'm Joe Graydon.
And I'm Terry Graydon. This podcast of the People's Pharmacy is brought to you by Squatty Potty Toilet Stools. They create healthy toilet posture for fast, easy elimination. Learn more about toilet posture and health at squattypotty.com. That's SQUATTYPOTTY.com.
We spend more money on healthcare than any other country in the world. Is our high-tech, high-cost medicine making us healthier? This is the People's Pharmacy with Terry and Joe Graydon.
American physicians have been taught that more tests and more aggressive treatment equal quality care. But some of the assumptions we all share about modern medicine are driving costs up without offering tangible benefits to patients.
Have we forgotten the pillars of good health that grandmothers around the world have known and practiced for centuries? Does their advice trump our ideas that sooner is better and there's a pill for every ill?
Coming up on the People's Pharmacy, Dr. Gil Welsh will tell us why less medicine may mean more health.
First, this news.
In the People's Pharmacy Health Headlines, peanuts have a place in a heart-healthy diet. For years, Americans were told to avoid nuts because they're high in fat, which was assumed to be bad for the cardiovascular system. Then, researchers found that people who ate more nuts, including walnuts, pistachios, and almonds, were less likely to develop heart disease, high blood pressure, or diabetes. The more nuts they consumed, the lower their chances of premature death. Peanuts have not received the respect that tree nuts get. That's partly because they're legumes instead of true nuts, and they're also less expensive than walnuts, pecans, hazelnuts, or almonds. A new study, however, shows that peanut intake is also linked to lower mortality. The study included more than 70,000 people in southeastern states and more than 130,000 residents of Shanghai, China. The researchers collected dietary information and followed the study participants for at least 5 years. Those who consumed the most peanuts were least likely to die from strokes or heart disease in both China and the U.S. Perhaps now people may feel peanuts are as worthy as pricier tree nuts.
Another dietary habit Americans were once warned against is drinking coffee. There were concerns that coffee would raise blood pressure and cholesterol, potentially harming the heart. More recently, coffee consumption has been linked to a lower risk of type 2 diabetes and Parkinson's disease. But a study of about 25,000 healthy middle-aged people in South Korea has just shown that coffee drinkers are less likely to have calcium in their coronary arteries. This is measured with a cardiac CT scan and indicates subclinical atherosclerosis. The individuals who reported drinking between 3 and 5 cups of coffee daily had the least accumulation of calcium in their arteries. While this does not prove a cause and effect relationship, it suggests that we can stop worrying that coffee will harm the heart.
Many doctors try diligently to get their patients' systolic blood pressure down to 120 or so. They may prescribe 2 or 3 different antihypertensive pills to try to reach the goal, especially in older patients. But a study from Italy suggests that moderation in blood pressure treatment might be prudent. The 172 elderly Italians in the study were attending memory clinics. 2/3 of them had dementia, while about 1/3 had mild cognitive impairment. Around 70% were taking drugs to lower their blood pressure. 24-hour blood pressure monitoring revealed that those with the lowest systolic pressure at or under 128 had a bigger drop in their performance on a cognitive function test than those whose systolic pressure ran higher. The investigators remarked that daytime systolic blood pressure between 130 and 145 might be the most appropriate once people pass 65 years of age. For people who were not taking blood pressure medication, the systolic blood pressure did not appear linked to cognitive decline.
Clostridium difficile, or C. diff for short, is a hard-to-treat intestinal infection that can cause severe diarrhea. An infection may greatly extend a hospital stay, and sometimes the diarrhea associated with C. diff contributes to a patient's death. Those who recover from an initial C. diff infection are at risk for a recurrence. Canadian researchers conducted a review of the records of people who developed a C. diff infection in 2 university hospitals in Quebec. They found that people taking acid-suppressing drugs such as pantoprazole were more likely to experience a recurrent infection. 29% of those on a PPI suffered such an event, compared to 20% of those who were not taking a PPI. Those on a PPI were 50% more likely to die from their infection. The authors urge doctors to consider discontinuing PPI prescriptions in patients who come down with C. diff infections.
Television commercials focusing on the dangers of low T have gotten many men to ask their doctors for a prescription. In 2013, prescription testosterone medicines such as Androgel or Axiron hit $2 billion in sales. But the FDA is nervous about this trend. The agency is warning doctors to limit prescribing testosterone only to men who have low testosterone levels stemming from medical conditions and confirmed by lab tests. That's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Americans have been told repeatedly that we have the best medical care in the world, despite the fact that we rank pretty low on most major health measures, such as longevity and child mortality. We are, however, number 1 in high-tech medicine and expensive screening procedures.
Americans have a medical culture that values tests, treatments, and aggressive care that can be appropriate in some circumstances. But does this approach also lead to overdiagnosis and overtreatment?
To learn more about the potential harms from too much medical care, we turn to Dr. Gil Welsh. He's professor of medicine and community and family medicine at the Dartmouth Institute and the Geisel School of Medicine at Dartmouth. He's also adjunct professor of business administration at the Tuck School of Business and professor of public policy at Dartmouth College. His latest book is Less Medicine, More Health: 7 Assumptions That Drive Too Much Medical Care.
Welcome to the People's Pharmacy, Dr. Welsh.
Thank you so much for having me.
Well, thank you so much for rejoining us on the People's Pharmacy. You know, when we talked to you last, we didn't get your story, your history. I'm especially interested in the fact that you were once upon a time a math teacher of all things, and we'd like to know how that has influenced your career as a physician. But start at the beginning. Give us a little background.
Well, I was brought up in Colorado. My father was a professor of political science, and my mother was she trained as a nurse during World War II. Then she stopped to work to raise the 3 boys, and then she was a hospital trustee for our local community hospital, and there were 2 hospitals in town, and my father was a political scientist, and so the discussions at our dinner table often revolved around what one hospital was doing and whether we really needed a second CT scanner, and those kind of health policy issues were part of the dinner table conversation. I went on to medical school, but before I did, after graduating from college in economics, I wanted to have a real job. And so I worked at a boarding school north of Boston called Brooks School, and I taught Algebra 1, Geometry, and Algebra 2.
So there's the math teaching background right there.
There's the math teaching, yeah.
And you learned to love math, and that will influence a lot of our conversation today. But you also ended up on a ship. How did that happen?
Well, after I completed medical school, I did sort of the old-fashioned rotating internship, and a little bit of surgery, a little bit of OB, pediatrics, and medicine. And I went into the public health service. I was a general medical officer, served up in Alaska in the Yukon-Kuskokwim Delta for a couple of years. And then I was on what they called the Ready Reserve, which was a group of government physicians who were able to reactivate to help meet special needs. And one of those needs was a NOAA vessel sailing from Townsville, Australia to Seattle. They needed a ship's physician. And I said, sure, I'll do it.
That must have been an interesting experience.
It was an interesting experience. For the first few days, the doctor was the only sick person on board. It was very hot in the tropics and not much wind, and we were rolling, and I was pretty seasick. But I got my sea legs, and we got farther north, and I got much more comfortable.
Well, the reason that we had an inkling that there was such a story is that you did disclose some of these things in your book, Less Medicine, More Health, which has a delightfully conversational tone, I must say. We've really enjoyed reading it. And we'd like to talk with you about the 7 assumptions that drive too much medical care.
So let's start with that first assumption that all risks can be lowered. Why is that not true? I mean, here we are, modern medicine. We have the font of knowledge. We've got the Institute of Medicine. We've got so many technologies available to us. We've got all of these drugs. Presumably, we could take care of just about anything that's thrown at us.
Well, let me just start by saying that these assumptions are really strong underlying beliefs held by the general public. But I'm not blaming the public for these assumptions. It's in part the messaging they get about medical care tends to exaggerate its benefits and downplays or worse, ignores its harms. And this first assumption that all risks can be lowered is just an extrapolation that if we can help someone who's at really high risk, which we can often we can take a person at dramatically high risk and lower their risk, that you can extrapolate that to, well, we can help everybody who's at minimal or low or average risk. And the truth is it's much easier for us to reduce a high risk than it is to lower an average risk. And the problem is that everything we do, all of our interventions have some harm. Clearly, some interventions have more harms than others. But as people's risk, and most of us are at relatively low risk for bad health events, it becomes harder to help them without the countervailing harms overwhelming that benefit. And that's probably best understood in high blood pressure. You know, people with really high blood pressure, there's no question we can help lower their blood pressure and help lower their risk of cardiovascular events. But it's hard to do that when someone's near average blood pressure. And we're now getting signals that, particularly with the blood pressure control and even more importantly with blood sugar control, that if we're too aggressive, we end up creating more problems than we solve.
Well, let me just ask you, because this is so controversial and has created such consternation in the medical community. It has to do with what do we mean by average, or what's called mild to moderate hypertension. There was an analysis, a Cochrane analysis, a group of independent experts who looked at all of the randomized control studies, and they found that treating mild to moderate high blood pressure with drugs did not make a difference in outcome. But their definition of mild to moderate would make most of your colleagues shiver and shake. So do you recall what mild to moderate is? Because most doctors would think that had to be treated.
Well, first off, we're undergoing a huge course correction in the profession as about which variable to care more about. Historically, there are two numbers to measure blood pressure. The top number is the systolic blood pressure. The bottom is the diastolic blood pressure. Historically, when I was in medical school, it was all about the bottom number, the diastolic blood pressure. And now we're undergoing as I say, a course correction and recognizing that, in fact, it's probably the top number that's the more important of the two. So this mild to moderate question first becomes which variable are we talking about, the top or the bottom? And without getting in too much in the detail, I think the one thing I want to be clear about is that in the last few years, there really has been a dialing back, and some of you may remember the report of the JNC8. This was the group that sort of makes blood pressure guidelines, actually relaxed their threshold and said that for most people age 60 and above, we shouldn't be starting to treat if their systolic blood pressures are under 150, while 5 years earlier it was under 140. And I think there is, even within the medical community, a growing recognition that we need to hit a balance here, and that lower is not always better, because the problem with low blood pressure or low blood sugar, it's the sort of thing that can make people fall. It's the sort of thing that can create other health problems. And so we have to be careful. Most of the benefit is to get people towards normal, but not take everybody and force them to be underneath a certain number.
Now, Dr. Welsh, I think probably a lot of our listeners never heard of JNC8 and don't know what it is, but when their doctor says, well, I know I told you last year that you needed blood pressure medicine, but now we've reevaluated and you don't need blood pressure medicine, I think a lot of patients would be pleased.
I think that's right. I think a lot of patients are pleased. Some are a little confused by that.
And a lot are confused.
And everybody should realize that medicine isn't a perfect science, and we're always reevaluating things. And I think, honestly, we're in the midst of a course correction, not only on blood pressure, but also on blood sugar, and rethinking about the balance between intervention and not intervening.
Well, when we talk about balance, we like to say you have to weigh the benefits against the risks. And we always hope that doctors and patients will have an accurate assessment of benefits and risks. But a recent publication in the JAMA Internal Medicine showed that, in fact, patients' expectations of benefits and harms of treatments, screening, one of your special interests, and tests are often unrealistic. And patients often expect more benefit than they will get, and they underestimate the potential harm. Would you care to comment, please?
Sure. I think that's true, but I want to be clear not to blame the patients. I mean, these are the messages they get in the media, they get from the advertising, the infotainment, everything. Not everything, but a lot of the messaging that they get about healthcare exaggerates the benefits and downplays the harms. And that's one reason I think it's important to temper those, and that's why I'm talking about these 7 assumptions and help people understand the other side of the coin.
You are listening to Dr. Gil Welsh, Professor of Medicine, Community and Family Medicine at the Dartmouth Institute and the Geisel School of Medicine at Dartmouth. He's also Adjunct Professor of Business Administration at the Tuck School of Business and Professor of Public Policy at Dartmouth College. His books include Overdiagnosed and the most recent, Less Medicine, More Health, 7 Assumptions That Drive Too Much Medical Care.
A new study that was just published in JAMA Internal Medicine reinforces what Dr. Welsh said about getting blood pressure too low. Older people in Italy who had their pressure under 128 actually had a greater cognitive decline than people who had levels higher than that.
So it suggests we shouldn't be too aggressive in treating blood pressure,
especially in older people. After the break, Dr. Welsh will tell us why he thinks too much of our medical care has too little value.
What happens to heart patients when their cardiologists are all at a conference?
And is there a downside to routine checkups?
We always assume it's better to fix a problem promptly rather than to watch and wait. Is that a fallacy?
Dr. Welsh will give us his prescription for fighting inaccurate assumptions that can lead to health care disasters.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339, online at uttercream.com.
And by Squatty Potty Toilet Step Stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
If you'd like to order a CD of this show, you can call 800-732-2334. Today's show, number 984. That number again, 800-732-2334. Online at peoplespharmacy.com.
Today on the People's Pharmacy, we're talking about America's love affair with high-tech medicine. Are we getting too much medical care and too little bang for our bucks? After all, we spend more per capita than any other nation on Earth, but we have less to show for it. To find out why, we're talking with Dr. Gil Welsh, professor at the Geisel School of Medicine and the Dartmouth Institute. His latest book is Less Medicine, More Health.
Dr. Welsh, we frequently are reminded that there are all of these problems with medicine today. It costs too much. People don't have adequate access. There's uneven distribution and too much bureaucracy. And yet your point is we actually have too much medical care but too little value. What do you mean?
Well, I think we've all been taught to be concerned about the problem of having too little medical care. And I think there's a growing recognition that the concern about having too little needs to be balanced by the concern about having too much. We have a very, if you will, frothy medical care system, and there are a lot of good aspects to it, but there are a lot of bad aspects too. There's a lot of money on the table. There's a lot of advertising on the table. There's a lot of promotions on the table. And there's a lot of true belief about, it's always good to get checked or have something done. And I think it's important for people to understand the nuance. And I want to emphasize I'm a conventionally trained physician, and I see the value of medical care, particularly for those who are acutely ill or injured, what you might call acute care medicine. But in many other settings, we have exaggerated the benefits of medical care. We've underplayed the harms. And we have to be careful not to medicalize everybody, particularly when people are well. But even when people are sick, sometimes the right thing to do is nothing and let them heal on their own. And we need to understand that balance.
Well, apropos of that, we came across a very interesting sort of news alert several weeks ago, in which there was apparently a study of how well people did when they had a heart attack during the national cardiology meetings, when presumably all the cardiologists are outside the hospital not doing the intervention, and people survived at least as well, maybe better, as when their cardiologists were there to take care of them. Now, a heart attack is a really serious and acute medical situation. I was a little surprised by that.
Yeah, that was a fascinating study, and I think the basic finding is when a lot of the cardiologists are away, fewer cardiology procedures are done. The ones that are continue to be done are those that are actually the most important, and so in fact the sorting gets done correctly. But we are very interventionist towards heart disease right now. And again, I think we're undergoing a bit of a course correction, and people are understanding, in part because there's more data out there that intervening on people who have stable heart disease may not produce much benefit. I want to say if I had a heart attack, an acute, big heart attack, I would want a cardiovascular intervention. But on the other hand, if I had stable angina, I would not. And that's the nuance we need to help people with, is something about, how bad your problem is does say something about what the benefit of treatment is likely to be. The harms, though, they're pretty constant. Whether you're really sick or just mildly sick, or whether you're well, the harms are relatively constant across that, but the benefits change greatly, and that's the kind of equation we need to help patients and doctors understand better.
You have challenged the concept of the routine checkup, and you also talk about something referred to as incidentalomas.
Yeah.
I wonder if you could tell us the story of Mr. Nadeau. Is that how his name is pronounced?
Nadeau.
And his routine checkup and his little old belly bulge.
Yeah, this was a story told to me by his son, who is a physician, who came up to me after I gave a conference, and he told me about his father who went in for a routine checkup, and his primary care practitioner examined his belly and felt that there was an enlargement in there, and that could represent an abdominal aortic aneurysm. And so he referred Mr. Nadeau for an ultrasound of the abdomen, and that showed that, in fact, he didn't have an abdominal aortic aneurysm, but it did raise a question of whether there was something concerning on his pancreas. And the suggestion following the ultrasound was that he should have a CT scan to see what his pancreas looked like. Well, he got a CT scan, and that showed the pancreas was normal, but revealed a nodule on his liver. And this is sort of one incidental finding after another. This nodule in the liver was then suggested that it should be biopsied, and it was biopsied by a gastroenterologist, and it turned out to be a collection of blood vessels known as a hemangioma. Well, putting a biopsy needle into a collection of blood vessels has a way of causing bleeding, and soon after that, he was in the hospital for about a week, received about 10 units of blood, developed urinary retention, was unable to pee because of the narcotics he was given for pain. And long and the short of it, this was a checkup that ended up costing $50,000 and leading to a week of hospitalization. And the patient could have died. He did not. But this is really a series of events driven by incidental findings that is unfortunately too common in medicine. And it's hard to find an error there. It's not clear who to blame on this, although maybe it should make all of us reconsider exactly what we expect from medical care and to what extent we want to be looking for things to be wrong.
And I assume that in Mr. Nadeau's case, the hemangioma didn't require any treatment.
No, other than blood replacement for the bleeding.
From the biopsy.
From the biopsy, yes.
So, Dr. Welsh, are you suggesting that we should all skip our checkups?
Well, I think I should disclose my conflict of interest here. I'm a primary care practitioner, and I've done a fair number of checkups. I think we should probably rethink what we mean by a checkup, and maybe we should change the language from a checkup to a check-in. I do think there's a lot to be said, particularly for older individuals, to have a relationship with a physician, someone who he or she knows and can share what's important to them and how they want to approach life and how they want to approach death. I think there's a lot of value in that. If the checkup becomes a high-tech search for early forms of disease, that's where we get into problems.
You talk about worrying people unnecessarily, and all you have to do is turn on the evening news, and you'll see commercials for prescription drugs. And they're kind of worrying you that you too might be depressed and maybe you need, Abilify. Or maybe you got, toenail fungus, and we've got, a wonderful new drug that could cure this terrible problem. And there are probably a lot of other conditions as well that people see on television and they go, oh, yikes, I might have that. I better follow the instructions on that commercial and ask my doctor if drug X is right for me. Your thoughts about this worry issue?
Well, I think your comments really point to the power of marketing in medicine, and that we probably all need to develop some of the same skepticism for medical advertising that we might have for car advertising or something like that. We need to recognize when people are purely trying to sell product, and make sure that we're not becoming medicalized simply by the advertising process.
Dr. Welsh, I'd like to ask you about assumption number 2, which is it's always better to fix a problem. This sounds a little bit like Benjamin Franklin's statement that an ounce of prevention is worth a pound of cure, although I think he was talking about fires in houses rather than health. So what about it's better to fix a problem?
Well, this is the chapter when I'm talking a lot about cardiovascular disease, because this is an area where people have really studied this question pretty well, and it's to the cardiologist's credit. And coronary artery disease is basically a plumbing problem. It's an obstruction to blood vessels that serve the heart. It's a good example where just because it's a good thing in one setting, it may not be a good thing in another setting. Fixing the problem of an acute heart attack is generally a pretty good thing to do, and that means to open up the blood vessel again and let the heart have blood. Fixing the problem of stable angina, though, which was examined in a trial called the Courage trial, looks like it doesn't provide any benefit, and it does put the patient at some risk. And then you have the fact that about 2/3 of cardiovascular procedures to open up blood vessels are in patients that aren't having heart attacks. And in fact, some of them have absolutely no symptoms. They're just patients who have abnormal coronary arteries. And one of them is former President Bush, who underwent a balloon stenting procedure to open up an artery that wasn't even causing him problems. And this created quite an interesting conversation among doctors, many of whom thought this was American medicine at its worst. So here's a case where it's not even clear what problem you're trying to fix. You have to make sure the problem really is a problem before you try to fix it, and you want to make sure it's a big enough problem that it's worth the side effects and the harms that always come with our efforts to try to fix things. And in cardiovascular disease, there are a number of conditions, both coronary artery disease and atrial fibrillation, where sometimes managing the problem is just the right thing to do.
Let's talk a little bit about diabetes, because that also fits under the assumption it's always better to fix a problem. And there was this amazing study called Accord. You probably know what it stands for better than I do, but these were people who had type 2 diabetes, and the assumption was, well, it's better to do something because these people are at higher risk for all kinds of problems. So let's bring their blood pressure down as close to normal as we can. Let's be very aggressive in lowering their blood sugar, again, as close to normal as possible. Oh, and by the way, let's also get their cholesterol under control. So the sort of the foundation of how to prevent problems associated with diabetes. The results surprised an awful lot of doctors.
Yes, they did. And I think particularly with blood sugar, we have to be really careful. The fact is we've now seen that efforts to turn people, diabetic patients, into, quote, normal patients and normalize their blood sugar with drugs can actually increase their mortality. So it's another area where we've just got to be careful that we don't create more problems than we solve.
Dr. Welsh, one of the things I really like about your book is that you have little prescriptions at the end of each of your discussions of these assumptions, a way for us to counteract the assumption. So what should we all be taking away from this idea that it's always better to fix a problem?
Well, make sure it's a problem to begin with. I think that's one of the most important things is, do you actually experience the problem, or is this a problem someone else is telling you about? And understanding that how much of a problem something is hugely relevant to what the net effect of the procedure or the effort will be.
You also mentioned ask about options and start slow. Why is that so important?
Yeah, if it isn't a major problem that's acutely right now, like a heart attack, you've got time. And when you have time, you can take a stepwise approach. And the smaller the intervention, the less risky the intervention, take that first, the simpler one. Take it first and see how it works with the problem before you ramp it up.
Now, a lot of our listeners might be going, well, Dr. Gil Welsh, he may be an internist, he may be a physician, but he's a therapeutic nihilist. Tell us a little story about your wife, Linda, and her experience with a very high fever.
Oh, yeah, I'd almost forgotten about this. This is actually when I was starting to write the book. My wife was fencing, and this is not the sport. This is building fences for our horses in the summer. And she was very warm, and she decided to lay down. The next day she was still warm, and she was laying in a dark room, and that's very out of character for my wife. And we said, geez, we took her temperature, and it was over 103. And for an adult, that's a pretty high fever. And then she began to had some difficulties thinking clearly, and that was also very unusual. And took her to see a doctor that wasn't her husband, and by then her fever was back to normal. She had a normal temperature, but she got in a car to drive home. The doctor said it probably was just a viral infection, and she was getting better on her own, which is actually exactly what I would have done, although I was glad not to have to be the doctor there. But she got in the car to drive home, and this was another warm day. It was about 90 degrees, and the car was sitting in the sun, and she drove the half hour back to the house with the windows up, and the car didn't have air conditioning, or the air conditioning didn't work. Air conditioning isn't that important in Vermont, only a few days a year, but that was a sign that she was developing another fever, because she was cold on a car that was probably had 130 degrees inside, because it's been sitting in the sun. And she had another temperature to 103.6 or something, and went back to the doctor, who immediately did blood cultures and did some lab work, and enlisted the help of a specialist in infectious disease. And turns out Linda had a rare tick-borne illness that rarest in a few cases per million, but that was easily treated with an antibiotic. But the infectious disease specialist identified that, and she's fine. But this was, to me, a good example of medical care at its best. There was a caring physician involved, who kept track of my wife, who did, I think, the right thing in the first wave, and then did the right thing on the second wave, which is to seek help, and the help was available. And so I think our system can do very good things.
You're listening to Dr. Gil Welsh, professor of medicine at Dartmouth. His book is Less Medicine, More Health.
Coming up, we'll find out if treating a problem sooner is better than waiting.
We usually believe that more information is better, but is that always true?
We'll find out about striking the balance between acting too soon and acting too late.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Squatty Potty Toilet Step Stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
And by Redix Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel soft and smooth. 800-345-7339, online at uttercream.com.
If you'd like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 984. That number again is 800-732-2334, or you can find it online at peoplespharmacy.com.
Today we're examining our assumption that when it comes to medicine, more is better. Our guest is Dr. Gil Welsh, professor of medicine at the Dartmouth Institute and the Geisel School of Medicine at Dartmouth. His latest book is Less Medicine, More Health.
Dr. Gil Welsh, assumption number 3, sooner is always better. What's wrong with that?
Well, this is the one that we've all been taught, right? That we should always try to catch things early.
Absolutely.
And we've really gotten that message most strongly in looking for early forms of cancer. And it is the area that most of my career I have spent time thinking about, this whole issue of early diagnosis. And I think more and more people are recognizing that our basic concept of cancer is changing. That when I was in medical school, anything labeled a cancer, the presumption was that if you didn't do anything, the patient would die of their disease. And now we're realizing there's a whole lot more heterogeneity in cancer than we previously realized. And it's been described as the barnyard pen of cancers, the birds, the rabbits, and the turtles. And the birds are the very aggressive cancers. And if you're trying to catch things early, you're trying to build a pen for this barnyard, the problem with the birds is they're already gone. They've flown away. And these represent the most aggressive cancers, the fastest growing cancers, the cancers that tend to be missed by tests, or even if they're detected by tests, they've already spread by the time they're detectable. The rabbits are hopping around, and you can catch them if you build enough fences. And these are the cancers that are slowly growing. That if screening has benefits, it's going to be on this group of cancers. And then there's this third animal. That's the turtles, and these are the cancers that aren't going anywhere anyway. And the problem is that none of us want to be treated for a cancer that's not going anywhere anyway. And yet early detection is best at finding the turtles. And yet we don't know which cancer is going to be a turtle. We just know screening can find a lot of turtles. And there are a lot of turtles to find out there. We now know that somewhere between 1% and 3% of adults harbor small kidney cancers. Over a third of adults have small thyroid cancers. About a third of women age 40 to 50 will have early forms of breast cancer. And over half of men over age 60 have small prostate cancer. So there's a big reservoir of early cancers to find. And that's the problem with a strategy of always looking earlier and earlier and trying to find more and more. Ironically, the disturbing truth is that early diagnosis can needlessly turn people into patients. It can lead to a lot more treatment.
And that leads us to assumption number 4. It never hurts to get more information, and that gets us back to that incidentaloma. And you tell us in the book about one of your patients, Mr. Baker, and his kidneys. Would you describe that story and why it's so relevant?
Oh, yeah, Mr. Baker. Yeah, this was a patient of mine who I first met early in my career when I got to Dartmouth. And he called me on the phone because he was hoarse. And he had been hoarse for 6 weeks and didn't feel sick, and that was concerning to me. It wasn't like he had a cold or some self-limited problem. So I walked down the hall at our VA hospital and asked our otolaryngologist, an ENT specialist, to look at him, and he did, and examined his vocal cords and found a small cancer, which he removed. And in fact, the hoarseness immediately went away, and Mr. Baker never felt poorly. And that would be the end of the story, except that somewhere along the way, someone had ordered a chest X-ray. And the chest X-ray was read as having a widened mediastinum. That's the space between the two lungs. And that was concerning that maybe there was another cancer in there. And the radiologist recommended a CAT scan. And the CAT scan said, no, the mediastinum is fine, but in fact there's a small cancer on his kidneys. And so this is a man who presents with hoarseness and ends up with kidney cancer. What was interesting about Mr. Baker is, though, when it was suggested to him that he had a kidney cancer and his kidney needed to come out, he said, "Oh, come on, you're kidding me. I come in with horses and you guys want to take my kidney out." He said, "Geez, couldn't we watch it and see whether this is a problem?" And this was kind of a new idea for me in the 1990s. But the patient was very interested in it, and I was beginning to look at data. And they were saying there were a lot of small kidney cancers. He wanted to watch it, and so that's exactly what we did. At first, we did it every 3 months and every 6 months. Sometimes it seemed to grow a little. Sometimes it seemed to get a little bit smaller. Ultimately, about 10 years later, he died of pneumonia and never had a problem with his kidney cancer. I actually had asked him if he would consent to an autopsy, and he did. And when we did that, we found, in fact, about a 5-centimeter renal cell carcinoma, but it hadn't spread anywhere. So this was an example of a place where, he lived 10 years with a diagnosis that, in many ways, we all wish he never had. And this deals with this assumption that it never hurts to get more information. And the fact is, sometimes you get more information, you get more things to worry about, and more things get done to you. And I think this is going to be only an increasing issue for patients because I think the value of information has become sort of a central tenet of the 21st century. There are companies that are interested in selling biomarkers, genetic testing, etc. And we really need to begin to separate what's just more data from what's really useful knowledge. And this is going to be a very important distinction to make as we go forward.
And that actually can be quite tricky because we have another story to tell about a person with kidney cancer. This is a friend of ours, Dave DeBronkart, who's sometimes known as E-Patient Dave. And he went in to see his doctor for a checkup and said to the doctor, "Gee, my shoulder is really sore. It's really been bothering me." So his doctor ordered some kind of imaging, I don't know what. And what they found in the imaging was nothing particularly about the shoulder, but they saw spots of cancer in the lungs. And it turned out they were metastases from a kidney cancer that was actually quite aggressive. And at that point, he was treated for the kidney cancer.
Yeah, he had those birds, the bird cancer versus the tortoise.
That's right.
That Mr. Baker had. So he was told by his physician, put your affairs in order, you've got only a few months to live. He went online and discovered something called ACORE, Association of Cancer Online Resources, talked to other patients, found out that there was, I think, an immunotherapy for some relatively rare kinds of kidney cancer.
Yep.
He went through the treatment, and now many years later, he is going strong. He was, in essence, cured because there was a treatment, all because of shoulder pain that led to a diagnosis, granted a little late, but it led to an effective treatment. So how do we balance this idea of too much versus too little, too soon versus too late?
Well, it's a tricky balance, and I think that the first thing is where do you start? And if you start with a problem and you're having a problem evaluated, that's a very different setting than not having a problem and looking for one. And that's a distinction that I think is very important to keep in mind. And there's a big difference between evaluating a problem that exists and seeking a new problem out.
Dr. Welsh, we'd like to go ahead and ask you about assumption number 5. Action is always better than inaction. I think this is kind of the default setting for American culture and also for American medicine. What's wrong with it?
This is where I consider surgery, which is probably our most dramatic action in medicine. And to encourage this question to at least be asked, is taking action always the right choice? And the reason not to take action, and when we're talking about an action of surgery, is all surgery involves some trauma. All surgery needs to invade the skin, which is a protective layer, and that in itself puts you at increased risk for infection. But the trauma also interferes with the body's ability to heal. So this is a chapter where I deal with things like back pain and surgery for back pain. And one of the findings in surgery for back pain is that this is an intervention that can take acute back pain and transform it into chronic back pain. And there's increasing amounts of data about this question of whether to intervene and how much to intervene on patients' back pain. And it's just an area where we, again, have to understand that it's not necessarily always in your interest to take action. That sometimes doing nothing is exactly the right thing to do and let your body heal.
You know, one of the possible negative consequences of surgery has to do with anesthesia.
Yeah.
And that's rarely mentioned.
Right.
And the idea that there could be cognitive dysfunction after surgery and that it could be long-lasting depending on the kind of anesthetic and maybe, you know, how long the surgery goes on or how complex it is, this is not something that's usually mentioned ahead of time.
No, and I think it just speaks to this general point that we need to have respect for all medical interventions have some harms associated with them, some more than others. But general anesthesia, although we do not understand the mechanism, has been shown to have some effect on cognition, particularly in older patients. And so this comes back to the whole idea of a stepwise approach. You know, first see if the simple interventions can help before you ramp things up.
Well, maybe what we need is a newer, better anesthetic. After all, isn't newer better?
Yeah, right. No, not necessarily. Newer. Let me ask you this: Do you buy a new car in its first model year? Do you want a beta test software? No, I don't particularly. I'd like to have something that's been tested. Anyone that knows the story of Vioxx, a medicine that was a new medicine that was supposedly better for your stomach and every bit as good as naproxen, but turned out to double or triple the rate of heart attacks and increase mortality, or a new therapy for metastatic breast cancer called autologous bone marrow transplantation, which went on for about 10 years, involved about 30,000 women till it was shown not to work. Or the metal on metal hips, you know, how good could that be? You got two forms of metal, they're just going to last and last, except they're going to rub on each other and put cobalt ions in your blood,
which could poison you.
Which has poisoned some people.
So that's assumption.
This is the whole question: is whether new is always the way to go. And the short answer is that the new interventions are typically not well tested. And they can be found to be useless and or harmful. And I think for most of us, the way to go is tried and true. You know, I want a drug, I want an old drug, not one that's outdated, but one that we have a good track record on. I want a procedure that my doctor knows how to do, isn't learning how to do, and guessing how to do. And I want devices that have been tested.
Well, that was assumption number 6. Newer is always better, and the answer, stick with tried and true. Let's move on quickly to assumption 7. It's all about avoiding death.
Yeah, well, this is the most personal topic, but I think sometimes in medical care we act as if it's all about avoiding death. And, of course, the language of saving life and avoiding death are actually shorthands for far less evocative terms, lengthening life and delaying death. And I think it's something we all need to think about, you know, to what extent is our life devoted towards trying to lengthen it, or is it about the quality of life in it? And you ask yourself this, you know, why do we climb mountains? Why do we swim in the oceans? These are things that entail some risks. Well, why do we do it? Because that's part of life. And I think if we get too focused on saying the only goal is to avoid death or lengthen life, it becomes a fixation that ends up diminishing life.
Dr. Gil Welsh, We want to thank you very much for writing this wonderful book, Less Medicine, More Health. What would you like our listeners to take away from it?
I think what I really like is people not to be scared about medical care, but to understand the nuances involved and understand that physicians who suggest not doing a test or not intervening on a problem may have their interests actually more in mind than the physician that always does another test and suggests another treatment. That there's a balance to be had here, and that sometimes the right thing to do is to watch and wait, is to let your body get better, is to use a drug that's been around for years and not the newest thing on the market.
Dr. Gil Welsh, thank you so much for talking with us on the People's Pharmacy today.
It's my pleasure. Thanks for having me.
You've been listening to Dr. Gil Welsh, Professor of Medicine, Community, and Family Medicine at the Dartmouth Institute and the Geisel School of Medicine at Dartmouth. He's also Adjunct Professor of Business Administration at the Tuck School of Business and Professor of Public Policy at Dartmouth College. His books include Overdiagnosed and the most recent, Less Medicine, More Health, 7 Assumptions That Drive Too Much Medical Care.
Lynn Siegel produced today's show. Al Wadarsky engineers the program. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Redx Industries, makers of Utterly Smooth Extra Care 20 Cream, with 20% urea for extra skin protection. The number's 800-345-7339. The website is uttercream.com.
If you'd like to order a CD of today's show or any other People's Pharmacy episode, you can call 800-732-2334. Today's show is number 984. That number again is 800-732-2334, or you can find it online at peoplespharmacy.com.
When you visit our site, check out prescription drugs, herbal medicines, and home remedies. You can share your own experience and thoughts on today's show.
Why not sign up for our free online newsletter or the free podcast of the show? You need never miss another People's Pharmacy program again, and you can share it with a friend. It's all there at peoplespharmacy.com.
Next week, please join us on the People's Pharmacy when we find the inside story about herbs. The New York Attorney General's office recently said that many of the herbs did not contain what they should. We'll get the straight and skinny from people who really know. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening, and please do join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to the People's Pharmacy.
We interrupt this program to bring you an important Wayfair message. Wayfair's got style tips for every home. This is Styles McKenzie helping you make those rooms sing. Today's style tip: when it comes to making a statement, treat bold patterns like neutrals. Go wild, like an untamed animal print area rug under a rustic farmhouse table from Wayfair.com. Arr, fierce. This has been your Wayfair style tip to keep those interiors superior.
Wayfair, every style, every home.